Good day, everyone. My name is Ethan, moderator for this webinar. Welcome everyone for today's webinar, Telemedicine, CMS, and TJC Standards. I would like to introduce our presenter for today, Darlene Evans. Darlene Evans, MSN RN CPHQ, is a nurse consultant for Nash Healthcare Consulting. Darlene brings 25 years of experience in the healthcare industry, specializing in clinical and regulatory operations, management, and accreditation readiness and response. I would now like to hand over the floor to one of the best speaker of Nash Healthcare, Darlene Evans.
Thank you so much, and thank you for joining us. So thank you especially for taking your time out to be with us in Nash Healthcare as we present the information on telemedicine, CMS, and the Joint Commission standards relative to telemedicine. We have a lot of information to share, and as always, Nash Consulting offers you many embedded resources and other slides for your referral and reading opportunities beyond this particular presentation. Also, we are available to you for any needs that you may have otherwise. So without further ado, we'll get started. So with that, we certainly, if you had not had any familiarity or any type of telemedicine, telehealth, or radiology type process service within your organization or in collaboration with a distant site, then certainly during COVID, many organizations face that opportunity, a positive one, we might add. So that was really the crux in the portion of the overview as a result of the pandemic, and that it quickly propelled us into these discussions. If you are on the call in one of those organizations, or if you're uncertain whether you are one of those organizations that didn't have prior services and was granted a waiver, that waiver was called an 1135 waiver, and it talked specifically about the capability of providing these services through various means and to include Medicare patients and service provisions. So as always, as I said, we provide you with a number of resources and information that you can refer to following this session, so please do so. So here you'll see again some various links and .gov sites that are available to you for the addressment of that. So the functional aspect, or I'll say operational aspects of the waiver and the process for that also allowed the provision of audio and video equipment permitting two-way real-time interaction. So later on you might hear the term synchronous or asynchronous. That synchronous aspect of communication allows that two-way communication in real time, again from one site to another or with one person to another in their setting. All right, contract with entity for telemedicine, and again, generally there is some type of contractual agreement. A lot of advantages, as I said, not only for that acute response for patients that certainly felt they may have been exposed to or actually contracted COVID, but also other care delivery means as well. So it had significant advantages for those organizations who had not really had those services or had a comfort level with those services, or the communities and patients with them. So this is a CMS document that is just, again, filled with a tremendous amount of resource information about the processes, and it's called Medicare Learning Network, and it does go over the billing aspects or other service aspects for telemedicine and telehealth. So, again, there was reimbursements under the waiver because of those emergency response needs that we had across the country, but also then there's still that payment and possibility of, again, a financial viability for the use of such service. So the standards and guidelines are pretty clear, and they are continuing to be addressed. So there are some comments and guides relative to mental health services, rehab, we'll say the EICU type video conferencing and those kind of things like that. So some of the practice guidelines that are out there now, as I said, they've either been an evolution or certainly have been just propelled as a result of COVID, and everything we're learning is just some of those, and the resources are tremendous about these service line capabilities. Then there's the American Medical Association Telemedicine Resources, and certainly there's again a extended amount of references here for the use within your organization. And again, they've been in place for years, and they continue to evolve. Part of this came from, as I said, is far back as in the 90s and certainly in the late 90s, where it was just far more appropriate to start developing some of these processes. So 2014 approved guidelines to help address that, and then those model policies that have to be in place, and then those references to the contractual agreements. And again, all going back to what are the roles and responsibilities of primary site and the distant site, i.e. hospital, clinic, individuals, entity group, how the oversight for monitoring the appropriateness of the care delivery, what is the satisfaction, how's it going to be annually reviewed, and ultimately that the medical staff and board and leadership of those entities really have the responsibility for the ownership of that care delivery process. Federation of State Medical Boards began to identify again the requirements again at primary sites or distant sites, and how and under what circumstances the use of that would be reimbursed. Then you get to some specific standards. So if you, certainly all organizations that provide care can be under the conditions of participation, but if you are also duly acknowledged, so in this case accredited by the Joint Commission or other like entities, they will have regulations around telemedicine and services as well. Okay, but foremost, absolutely the credentialing and privileging process, or the accountability for having providers and clinicians working within the scope of their practice within the states that govern their service and licensure will be imperative and absolutely will be looked at. So 04, 03, 09 EP 23 again talks about that originating site, and again it's through that agreement, so they'll quite often pull those contracts and they'll look to see when they were approved, the time, expiration dates, the manner in which clinical services were evaluated, how that is integrated into the body of the hospital for performance improvement. So again, just saying this in a different way, distant site hospital or distant site telemedicine entity, it might be a service, it might be a clinic, it might be something else. So again, knowing the vernacular and what we're talking about as it relates to your organization, I'll say, and then that distant site organization. And then the Federal Register, again, that goes back to your conditions of participation. If you really have an oversight or even another entity like your third-party credential verification organizations or your CVOs, that everybody understands what their roles and responsibilities are. Making sure, again, that you look, and again, with any type of care, you want to also read those EMTALA regulations for, again, how it applies to you, what types of, I'll say, instruction and services can be provided and under what circumstances. So I mentioned to you, so there's telemedicine and telehealth, how we look at that and the clarity of that word usage. We talked about simultaneous and non-simultaneous. And then I'll pause here going back to who's all involved. So if you've offered various types of services, so whether it's podiatry or assessments for dermatology, or it is COVID follow-up or monitoring versus care delivery, different types of things like that. Who's doing that? Who's involved in that? What's their roles and responsibilities? Does their scope of practice and law and regulation support that? With that, again, I thank you for your participation today.
Thanks, Darwin. That was a wonderful webinar. It was a very detailed and resourceful, and that does conclude the session for today. You may all disconnect now. You all have a great day ahead.